Hi, my name is Hannah Jackson, and I will be talking a bit about one of the biggest issues surgeons face with the Da Vinci surgical system by Intuitive. So, the Da Vinci surgical system is a robotic surgical system made by the American company Intuitive Surgical. It was approved by the FDA in 2000, and it is designed to facilitate surgery using a minimally invasive approach, and it is controlled by a surgeon from a console. So, the Da Vinci consists of three components: the surgeon console, which the surgeon uses to control the instruments and view the patient anatomy in 3D, the patient cart, which holds the camera and instruments the surgeon controls from the console, and the vision cart, which allows for communication between the components and supports the 3D high-definition vision system. So some of the benefits of the Da Vinci system include better precision, as the doctor sits at a computer screen that magnifies all the intricacies of the surgery, allowing them to see much more clearly. Faster recovery time, because robotic surgeries are less invasive than other types of surgery, so recovery time is usually shorter. Less blood loss, because the incision required for robotic surgeries is much smaller than typical surgeries, so less blood is lost during the procedure. And less scarring, because the incision for robotic surgery is considerably smaller, the scar is much less noticeable. Despite the benefits, there are risks to the system as well. So some of the risks include device malfunction, possible burn, cuts, or tears, which can occur when the robotic hand gets too close to another organ during surgery, causing damage, and doctors lacking an experience, which results in the most complications and poses the biggest risk. So, if you've never heard about it, there's a documentary on Netflix called The Bleeding Edge that investigates the medical device industry. And one of the stories focuses on a woman who had undergone a hysterectomy performed using the Da Vinci robot. So the woman spent one night in the hospital after her hysterectomy. She felt good and was walking around pretty quickly. But about a week later, she was rushed to the hospital with an infection in the area that was stitched by the robot during her hysterectomy. 2 months later, she was back at the hospital for another emergency surgery. And this occurred because while her and her husband were camping, the woman went to use the restroom and 3 feet of her large intestine fell out. Believe it or not, this actually happened. What happens to the woman is called vaginal cup dehiscence. I'm sorry, I say this wrong every time. Vaginal cup dehiscence is rare, but potentially morbid, and it's a complication of a hysterectomy. After removal of the uterus, the vaginal incision is typically sutured closed. Vaginal cup dehiscence refers to separation of the vaginal incision, and this complication occurs about 0.3% of the time during a vaginal hysterectomy, 0.87% for laparoscopic, and a whopping 3.3% for robotic assisted. So why is the rate so high for robotic assisted surgery? Well, one of the reasons goes back to the Da Vinci's pre-market approval. So Intuitive initially submitted the Da Vinci robot through the FDA's pre-market approval process. That is, it is considered a Class 3 high-risk device. But an FDA manager intervened to have it approved through the 510(k) process instead, which is a much simpler approval pathway. Originally, Intuitive told the FDA that a huge amount of training would be provided as part of the sale of the machine to hospitals, but shortly after the FDA gave permission to market, Intuitive scaled back all of the training requirements. The rationale was that if surgeons needed 9 weeks of training to use it, no one was going to buy it. So surgeons who used the Da Vinci robot themselves said it took much longer before they felt proficient, and when surgeons perform robotic-assisted surgery without proper training, the results can be catastrophic, as I just previously discussed. Currently, there is no training requirement for surgeons to use the Da Vinci system. So following the rapid adoption of this technology in the field, many established open and laparoscopic surgeons undertook robotic surgery without following a standardized, validated robotic curriculum. Robotic surgery competency is determined by the medical institution and can range from 2 days to 10 weeks. So you have surgeons who operate for half a day on pigs, take a 10-question multiple choice test, and have a proctor. And then you have another surgeon do 2 surgeries, and then they're essentially turned loose. Because of this, there is a need for formal assessment of competency in robotic surgery to ensure safe and sustained growth. So the training for the Da Vinci robotic system can essentially be broken down into 3 categories: patient-side training, console training, and non-technical skill training. So patient-side training consists of 2 key components: patient port placement and basic laparoscopic skills. So proper patient positioning not only ensures that each member of the surgical team, such as the assistant and scrub nurse, get adequate access to the patient, but also maintains an optimal spatial configuration between the patient cart of the robot and the target organ. Similarly, correct port placement enables access to target organs, allowing for triangulation, which without any instrument clashes. And you can see an image of like potential port placement for the robotic system. Basic laparoscopic skills required for a robotic surgeon include laparoscopic access, takedown of adhesions that prevent port insertion, application of clips, suction, and retraction. So these basic skills can be acquired in a dry lab and fine-tuned during bedside training. The acquisition of basic laparoscopic skills has its own learning curve, but has been shown to ease the development of robotic skills on the console. The second element is console training. So similar to any advanced technological training, knowledge and working of the console is of paramount importance. Online modules are available that introduce the basic concepts of the currently available system, and most modules also provide information on troubleshooting. So proficiency in these basic console skills, such as camera, pedal, finger control, can be achieved in a relatively straightforward manner in a dry lab or VR simulated environment. Advanced console skills need to be developed in a mentored simulation environment, either undertaken in a VR simulator, a dry lab, or a wet lab. Non-technical skill development is just as important as technical skill development, and the presence of the robot in the operating room poses a unique challenge to team communication and risk management, and hence development of non-technical skills is of paramount importance. So studies in open surgery have identified that 86% of adverse surgical events were due to system errors, and were not related to technical skills at all. Overall, 40% of intraoperative errors were found to relate to failures in communication alone. So non-technical skills such as teamwork, leadership, situational awareness, and decision-making have all been shown to have a significant impact on surgical success and can be developed easily in a simulated environment. With all of the training components in mind, it's important to implement a standardized training protocol. So the importance of having a validated training curriculum not only stems from responsibility towards patient safety, but also from ensuing issues with credentials and associated liability. So in 2012, a consortium of experts set up a Fundamentals of Robotic Surgery, or FRS program, which is very similar to the Fundamentals of Laparoscopic Skills. The program consisted of a curriculum of lectures, psychomotor skill labs, and team training activities, and 25 specific outcome measures are used to assess the achievement of robotic surgical skills. Studies done have showed that the curriculum significantly improves basic robotic skills in residents who undertook it when compared to those who did not. More recently, a curriculum for robotic fellowship training based on structured focus group interviews has been created. It takes the novice surgeon through online teaching, simulation in the laboratory environment, full immersive modular training at the workplace, and final sign-off of videoed full procedure and trainer's report for certification. And it's estimated to take about 3 months to complete, which is a long time. A combined curriculum has been proposed that has elements of each, and this is the curriculum that I recommend. So this curriculum has been evaluated on novice surgeons and demonstrated that the learning curve for functional recovery can occur within the first 50 independent cases as compared to hundreds of operational cases. The curriculum would be standardized and consist firstly of online e-learning, after which a certificate will be awarded for completion. Then there will be video-based discussions of procedures as well as hands-on team training on patient position, port positioning, and robotic docking. The next week will consist of mentored virtual reality simulation on basic and advanced tasks, and trainees can only move on after reaching a certain score. They then move on to dry lab simulations where they must have a ROSAT score of greater than 18 for each task. That number is also arbitrary. It could be greater than any score. That's just a standard high achieving score. But the same goes for the wet lab simulation. They then move on to modular training in the operating theater, and once this training is complete, the surgeon can be considered console proficient. So thank you for watching. I want to end this presentation by thanking y'all, and I hope you enjoyed learning.